Moving forward to our next session, esophageal cancer. I would request the moderator, Dr. K Mishra, to kindly please join us on the stage.
From the scintillating debate between the stalwarts, we now move on to some of the mundane things, from augmented realities to some clinical decision making. And today, my mandate in the next 40 minutes is complete clinical response after neoadjuvant in carcinoma esophagus. What is to be done, right? So, I invite on stage the panelist for this, Dr. Mathew Manipadam. He is a GI surgeon and GI oncologist, senior consultant at Lakeshore Hospital. Dr. John, he had a very beautiful lecture on multimodal therapy in stomach in this conference earlier. Dr. Saurav Ghosh, he is oncosurgeon. Welcome, Dr. Saurav, in Kolkata Medical College. Dr. Sayan Paul, radiation oncologist, Apollo Gleneagles Hospital, Kolkata. He's a radiation oncologist. Welcome, Dr. Sayan. Then we have Dr. Amit Dutt, Dwary, medical oncologist, Apollo. Welcome, Dr. Amit. And we have Dr. Rajesh Panwar. Dr. Rajesh Panwar is GI surgeon, GI oncologist. He is assistant professor at All India Institute of Medical Sciences, Delhi. So this is a case-based discussion, and we will just put up a small case and we'll go around it. Esophageal cancer, as you know, is the 6th most common cause of mortality in the world. Most patients are diagnosed in their late stages and the survival remains poor. Tumor in C2 and T1A tumors, endoscopic resection for locally advanced esophageal cancer. T2 to 4A, neoadjuvant chemoradiotherapy, perioperative chemotherapy or preoperative chemotherapy followed by surgery has been used to prolong survival compared to surgery alone. So cross-trial firmly established neoadjuvant CRT strategy, paclitaxel and carboplatin based. Benefit was seen in both SCC, more than 49% had pathological complete response, as well as in adenocarcinoma where the pathological complete response was less. NCCN prefers NSCRT strategy with strong recommendation. Recently, studies have suggested that patients with pathologically complete response may benefit from observation and salvage resection strategies, and this is what we are going to discuss today. So the idea comes from watch and wait from rectal cancer, as also definitive chemoradiotherapy from cervical esophageal cancers. Now our case is a 72-year-old male, diabetes mellitus, hypertension, 1 month history of progressive dysphagia, first to solids, then progressing on to liquids. Upper GI endoscopy was done last year, 21st June. Ulceroproliferative lesion was there from 30 to 37 centimeters. Biopsy was done, which showed moderately differentiated squamous cell carcinoma. So this is our case profile, and I would ask my surgeon, Dr. Rajesh, what would you do, CCT or PET CCT? What is the choice of investigation?
So ideally, I would like to do a contrast enhanced CT with PET if it is available. Otherwise, I'll do CCT first, and then based on that, I'll decide to do a PET scan later on.
Is it the same approach, Dr. Amit?
So, sir, PET scan should be preferred if there is a facility to do so, because it changes the decision compared to CT scan in 20% of the patient. It varies from series to series, so 5% to 20% are usually upstaged compared to CT versus PET scan. So if there is a facility of doing PET scan with an IV contrast CT, that should be the modality of choice. If not, then CCT scan of the chest and abdomen is good enough.
Dr. John, would you say the same thing?
Yeah, I agree that PET scan will surely find out some metastatic disease which we would not find. So in the NCCN guidelines also, PET is indicated for esophagus. So I would prefer a PET CCT.
So when we see that we compare the CCT versus PET CCT, both CCT would be required, both chest and abdomen would be required. The response assessment facility would not be there, it is poor, although it gives us good spatial resolution, which may not be available in all the machines with PET CCT. Good quality scans are easily available. In PET CCT, we have cost and availability issues. Then in CCT, we may have to again do PET CCT if there are doubtful lesions, and it may still require PET evaluation. And doing both would increase definitely the radiation. In PET CCT, we may have some false positives, and which may be an issue at times. So this was the PET CT in our patient. The PET CT was done. We can see a lower esophageal growth over there. All the images are displayed over here. So this PET CT showed that it was FDG EVIT, 12.6 SUV. Circumferential thickening, maximum thickening was 1.7 centimeters, involving 11 centimeter of esophagus, with narrowing and proximal dilatation. Fat planes with aorta were preserved. Mild FDG EVIT paraesophageal lymph node was done. Non-FDG EVIT sub-centimeter gastrohepatic lymph node was there, and there was no uptake elsewhere. So what should be done next? So in our further investigation of this patient, what should we do? Is there a role of EUS?
I don't think here there will be any role of EUS. First of all, EUS will not be possible in such a large lesion. Scope will not be negotiable, and your EUS examination will not be complete. Even if you are able to do it, it's unlikely to change any management, because the role of EUS comes in early stage disease. MRI still is in infancy for CA esophagus. I don't know it will change anything.
So we go to our surgical oncologist, Dr. Saurav. What is the role of EUS in these patients? CA esophagus, firstly in this patient and then otherwise.
Hello. Yeah. So in this patient, if it is a stenotic growth, for an endoscopic ultrasound to be successful, the scope needs to be negotiated. It may not be technically possible in a growth which seems to be slightly big. So, and plus the role for EUS might be to establish the nodal status. So although there is uptake on the PET, that is not conclusive for metastasis. That may be due to some infective cause or granulomatous disease. EUS guided FNAC that allows us to document whether the periesophageal lymph node is actually metastatic or not. So that is a specific. Otherwise, again, I would agree with him that EUS is more important to define a T1A from a T1P or a T1 from a T2 lesion. In a very advanced tumor, maybe EUS may not contribute that much of information.
Dr. John, any role for MRI in these patients?
I feel, as the surgeon said, we feel CCT and PET is definitely better. MRI is still not evolved so much in staging CA esophagus, especially the local invasion, and we feel more comfortable with the CT.
Is it only a matter of being comfortable interpreting it, or there is more to it?
Yeah.
Swallowing may give rise to artifacts also in MRI. Data acquisition time is a little longer.
That's right. So, role of EUS, as our panelists have said, is in early stage esophageal cancer. FNAC of suspected lymph nodes can be done for accurate staging. Identification of G junction and Sievert types may be sometimes useful with EUS. As far as MRI diffusion weighted images are concerned, a low apparent diffusion coefficient indicates malignant tissue, can be used for response assessment. At present, its use is only for problem solving and where CCT is not possible. So, panelists agree with this? So patient was planned for CT-RT. In this patient, no further investigations were done. Patient was planned for CT-RT followed by VATS esophagectomy. He underwent neoadjuvant CT-RT cross regime, 23 fractions of RT. Last was on 23rd July 21. Chemotherapy 5 cycles, paclitaxel, carboplatin. So here we have to bring in our radiation oncologist, Dr. Sayan. Chemotherapy or chemoradiation?
So as it is a squamous cell carcinoma, I will prefer to use cross regimen here. Had it been adenocarcinoma, chemotherapy, perioperative chemotherapy would have been another option and equally effective option. But for squamous cell carcinoma, my preference will be to use the cross protocol with radiation.
Is there a kind of comparison of these two regimes in the literature?
In cross protocol, in squamous cell carcinomas, the response was, I think it was around 59%, and for adeno it was around 30%. So squamous cell carcinoma, the response is obviously better than adenocarcinoma in cross trial. But if you say that there is a head-on comparison between a randomized control trial between a CT-RT and perioperative chemotherapy, I think there is none. And I don't think it will be very much feasible to do that also.
In fact, in the cross trial, if I remember right, most of the patients were of adenocarcinoma. 75% patients were of adenocarcinoma.
Yes, but the response was better in squamous cell carcinoma.
So, Dr. Amit, what would you say, chemoradiation or chemotherapy?
So, sir, we mostly go by chemoradiation based on the cross or the Dutch trial that they did. But there are, literature to tell you whether, chemotherapy only can be considered or not. So there are 2 RCTs and 1 meta-analysis also which included those RCTs, and they told that when chemoradiation is used, survival seems to be little better because the hazard ratio in that meta-analysis was 0.80, which tells you that 20% of the patient are more likely to not be dying, when you use chemoradiation versus chemotherapy alone. But then the quality of evidence is moderate, as the Cochrane puts it up. There is no great, there are better studies needs to be done to understand whether CT-RT or only chemo. Usually it's CT-RT when we talk of esophageal cancer, but when it comes to G-junction tumor, you do have an option of doing perioperative chemotherapy like a FLOT, which was directly compared against, ECF, and that was better both for DFS and OS. So this is, how I will like to summarize it, sir.
Okay.
For chemotherapy also?
Probably we'll have the participation of the audience. Last 5 minutes we'll save for that. We can go with. So, multimodality therapy is the preferred approach. Optimal content and sequence continues to evolve. Definitive or neoadjuvant CRT followed by surgery for esophageal carcinoma and Sievert 1 and 2 have been preferred, while perioperative float have been mainstay in CA stomach and Sievert 3. Is that right? Okay. So there was this 80803 CLGB trial. This used induction chemotherapy and then PET CT guided whether if it was effective. Then in responders it was continued, and in non-responders chemotherapy was changed. So although advantage over CRT has not been demonstrated, this may be an important avenue for research in future, although superiority over CRT has not been addressed. Dr. Amit mentioned that there have been trials. Chapin et al. Had reviewed neoadjuvant and adjuvant strategy in December 21. No one chemo regime was found to be superior given with radiation. Fan et al. Did a meta-analysis, chemo versus chemo radiation, published in E-Clinical Medicine. Both NCT and NCRT improved overall survival in comparison to surgery alone in SCC. NCRT and NCT both could be used in esophageal SCC, but optimal strategy was still not clear in adenocarcinoma. This was because the studies were mixed and there were differing protocols. NeoAGES trial, Reynolds et al., 362 patient, 178 cross and 184 were magic float. 3 years estimated probability of survival was 56 and 57%, and other parameters were also not significant. So in this patient, after the treatment, there was a complete response, and these are two comparative figures that you see before and after. So this patient showed a complete response. So the issue comes, one of the response assessment that we have seen over here is by PET CT. What would be the mandatory tests that should be done for response assessment to say that it is clinically complete response? And second issue is how accurate it is. Dr. Saurav.
We would need to do a PET CT scan, and we also would need to do an endoscopy, upper GI endoscopy with biopsy of any suspicious area.
So endoscopy and biopsy and CCT, this PET CT would be the mandatory investigations.
Yes.
Would you also do US?
If the facility for US was there and the PET CT was equivocal, I would use the US as a problem-solving tool.
Dr. John?
Yeah, I agree with what he said, that PET CT first, followed by an endoscopic biopsy. US may or plus or minus based on, most likely with these two investigations, we would reach to a reasonable conclusion that whether a complete response has been achieved or not.
Dr. Rajesh?
My strategy would be slightly different. First, I will assess whether I am planning a surgical resection in this patient or not. Is the patient fit enough for surgical resection? And if he's fit enough and I am contemplating that I am going for surgery in any case, even if it is complete clinical response.
Now, since we are discussing that if there is a complete response, can we omit surgery? So we need to know what would constitute a complete response.
So complete response in my view would be a absence of uptake on PET CT as well as complete healing on an endoscopy without any ulcer, and if there is an ulcer it has to be biopsied.
In this conference itself, platelet to lymphocyte and platelet to neutrophil ratios have been given.
Neutrophil to lymphocyte ratio has been shown that it can predict that pathological complete response is not there, but it is still not a norm. So it is still under evaluation.
Dr. Sayan, how accurate is this response assessment?
Yeah, there has been studies to compare different modalities to assess the complete response. Only two modalities have been found useful. One is the PET CT, another is endoscopic ultrasound. But endoscopic ultrasound may not be feasible for all the cases. And then PET CT is the only one. The thing is that even if there is a complete response, so in studies, even probably in CROSS or I'm forgetting the name of the trial. So even with a clinical complete response, it does not completely correspond to the pathological complete response. So to be quite frank, we don't have a very good imaging or very good investigation modalities in hand to predict that these patients have a complete response or you will have a pathological response also if we are not planning for surgery.
Dr. John, how accurate this is? And say suppose this is not accurate, would you also like to include say US or US guided FNAC?
PET CT has 82% I think sensitivity and 14% negative predictive value.
Okay. Dr. John?
Yeah, I feel none of these tests are 100%. So if the patient is fit and it is probably safer to do, go ahead with surgery on the longer run.
Okay, so this was a nationwide cohort study, pathological tumor response assessment. This was following the CROSS neoadjuvant regime, and 4,946 patients, 24% patients achieved complete pathological response. In SCC, this was 42%, adenocarcinoma, it was 19%. Complete responders, 5-year overall survival was 62% versus 38% in non-responders. When it was well to moderately differentiated carcinoma or adenocarcinomas or signet ring cell was there, higher lymph node yield was there, higher T and N positive were there, then these were less likely to have a pathological complete response. There's no universally agreed grading system for tumor regression, but TNM was a good prognostic model for reporting, which is being followed. So if we see what is the accuracy of this or predictability of this complete response, endoscopy, positive predictive value is very high, but negative predictive value is low. So endoscopy and biopsy had something around 50% kind of accuracy in most of the studies. US can show responders and non-responders, but accuracy of complete response is quite low. But positive FNAC from lymph node may be useful if we use US. Biomarkers, all these ratios, etc., they are under evaluation and very little data is there. FDG PET post chemoradiation, there is esophagitis, which renders SUV values as inaccurate. Although responders can be predicted, but complete response prediction is inaccurate when compared to the pathology. So in this patient, VATS esophagectomy was done with cervical anastomosis, feeding jejunostomy. Post-operative period was uneventful. Patient was discharged in the on post-operative day 8. So one further question comes: what should be the time to surgery? And maybe radiation onco. And Dr. Saurav, you can answer this.
We would prefer to do the surgery within 6 weeks of completion of the chemoradiation treatment.
Dr. Sayan?
Yeah, 6 to 8 weeks, yes.
Any reason? Why would you do it 6 weeks, not at 8 or 12 weeks?
Patient after the chemoradiation, neoadjuvant chemoradiation, the patient needs some time to recover also. Because at least 4 weeks time it will need to recover from the radiation and chemo side effects.
And also, I think radiation keeps working like in rectal cancer. You don't want to do too early before the radiation has achieved its
We need to give some time to.
Optimal time interval after neoadjuvant therapy is not known. Patient status, local inflammation and tumor response can improve over time, but theoretically advancement may also be detected. There were 2 large register-based cohort studies showed improved histological response but decreased survival. Some other studies found none of these association. And there was a recent 2020 study on Swedish population which showed that the analysis was between 49 days or less, that is median 31 days, and 50 days or more, median 71 days. There was no difference in survival, complete response or post-operative outcomes. So this
there was a study by Donahue which compared anastomosis, a surgery done before 35 days from completion and after 35. And they showed that delayed surgery was associated with a higher leak rate. Probably because of more fibrosis, it became technically difficult to take up the conduit and all. So
there are so many things, but not universally agreed upon. So we'll now we come to our final question, that whether the surgery can be omitted in the patients which have complete response. Dr. Rajesh.
So complete clinical response is not synonymous with complete pathological response, and as the data suggest, it's between 30 to 40% of complete clinical response will not show a complete, that means 60 to 70% pathological complete response will be there. There will be 30 to 40% patients who still harbor the tumor. And at present, there is no way for us to select out those patients. Here comes in the role of tumor markers like neutrophil lymphocyte ratio. So right now, you have to tell the patient that, see, you have a complete clinical response, but still there is 30 to 40% chance that you may harbor a tumor and that is going to recur. So if the patient is very fit for surgery and risk is lower than 30 to 40%, then definitely I would offer surgery. But if the patient is already frail, and there are chances that he will develop complications and quality of life may be poor after esophagectomy, those patients can be given a trial of conservative management and watch and wait policy where you look for recurrence and then do a salvage esophagectomy.
Sayan.
So first of all, if we had planned for a planned surgery and we have given neoadjuvant chemoradiotherapy, surgery must be done. So because that was the plan before starting the treatment, and if we use cross protocol, we use a little lesser dose. than a definitive dose. So if we have used cross protocol, and even if there is a complete response and patient is resectable, be it surgically and medically, if patient is medically unfit or patient is unresectable, then only we can have the strategy of just following.
That's a very valid point. Dr. John, what would you say?
Yeah, I agree that definitive chemoradiation, if given, then probably we can wait. This the neoadjuvant regimen definitely is lesser radiation. So,
but there was a Cochrane review, and this was by Wellhappen et al., and they reviewed pathological complete response patient, those who had only received chemoradiotherapy and they were observed, and those who had chemoradiotherapy plus surgery. Overall survival at 2 years was just the same. Only thing that improved was loco-regional relapse, which was better in patients with chemoradiotherapy and surgery compared to the only chemoradiotherapy after this cross kind of a regime. So there is some evidence that these patients, if they are left alone without surgery, they would do as well as only say chemoradiotherapy. And the source of this problem is that mortality was 1.9% in only chemoradiotherapy patients, whereas it was 9.5% in patients who had chemoradiotherapy plus surgery. Then there was this review by Park et al. That omitting surgery in CA esophagus patient after neoadjuvant chemoradiotherapy. There were 6 articles, 609 patients, 10-year study from 2010 to 2020. Omitting surgery provides better 2-year overall survival in complete responders after neoadjuvant chemoradiotherapy. There was no significant difference in disease-free survival. Surgery could increase morbidity and mortality and decrease the quality of life. Retrospective studies mostly, doses of radiotherapy, as Dr. Sayan has also pointed out, were heterogeneous. Survival data was only of 2 years, and adenocarcinoma and squamous cell carcinoma were not separately analyzed. So, because radiotherapy as well as surgery is the local treatment, so having both of them over there may be an over treatment for some of these patients, especially who are high risk patients. So possible conclusion could be that surgery may be an over treatment in some of these cases and could be omitted in high risk cases of SCC at least. Does the panel agree with that, Dr. Rajesh?
Yes, sir. In fact, there are 2 trials going on to answer this question. One is the SANO trial and one is ESO-STATE trial. The results, they say, would be out in end of 23. So maybe we would have slightly better data to make decisions. Right now, it's difficult for me to offer a conservative management to a patient who is absolutely fit for surgery. But I may think of offering conservative to a person whom I think would be very high risk for surgery.
Dr. Saurav?
If you could go back to your previous slide, sir, this trial. Yeah. So although you mentioned that the data for adenocarcinoma and squamous were not separately analyzed, in this trial, out of the 609 patients, 500 patients were squamous. So whatever conclusions if we have to draw from this have to be kept in mind only for the subset of squamous. As we have all seen that the complete response rates are better in squamous, not so well in adeno. Secondly, if this is one meta-analysis which is in favor of not operating, there is one meta-analysis by Wang et al. Which was in 2018, I think in radiation oncology, which showed that there was a slight benefit, although it did not reach statistical significance, in favor of adding surgery to chemoradiation as compared to chemoradiation alone.
So agreed. So I think
most of the standard guidelines would still say that you have to do a surgery if the patient is fit.
In that analysis also, it was 2 years, it was p-value was around 0.06, and 5 years there was no difference.
There was no difference, yes.
At 5 years there was no difference. So 5 years survival is similar.
Okay. So there are problems, response assessment. Clinical complete response is not equivalent to pathological complete response. There is a difference in the nature of squamous cell carcinoma versus adenocarcinoma, and it has to be done with risk analysis, kind of comorbidities the patient has, ECOG grading, reducing mortality due to the procedure itself. Is that okay? So, as far as the histopathology is concerned, CA esophagus post neoadjuvant chemoradiotherapy. This is regarding our case. This was the histopathology. Moderately differentiated squamous cell carcinoma, no lymphatic or venous invasion. Tumor bed shows macrophage infiltration and fibrosis, 2 centimeter in largest dimension, circumferential involvement, small groups of cells were present in muscularis propria, all margins were free, 0 out of 26 lymph nodes, modified RAN scheme for tumor regression was 1, and the grading that was given was YPT2N0. So what is the status of adjuvant therapy, Dr. Amit? Adjuvant therapy for complete clinical response, for pathological complete response. Would you advise any adjuvant therapy for these patients? They have had this cross regime.
So like your case, sir, what you said that,
Yes.
It was thought to be PCR, but it was not actually PCR because there was something, viable you could got on the final histopathology report once the surgery was done. That's what you showed, sir, in the previous slide?
Yes.
Yeah. So, in these cases, there is a role of immunotherapy, Opdita, which was in an EGM paper. That said that if you give Opdita or nivolumab for 1 year, the DFS rates can be just doubled, so 22% versus 11%. So this is going to be a big game changer. I believe that those who have anything residual after the surgery, they should, irrespective of whether they are squamous or adenocarcinoma, should be offered immunotherapy, and that benefits.
Very correct. We are running short of time now, and we should have some amount of audience interaction also. I can see Dr. Vivek itching. And so the current evidence for benefits of adjuvant therapy after neoadjuvant CRT and esophagectomy is unclear. Few studies have suggested that it may reduce overall survival also. Checkmate 577 trial, NACRT with esophagectomy with incomplete response. Nivolumab versus placebo, median disease-free survival was 22 months compared to 11 months with placebo, and grade 3 to 4 adverse events were 13% versus 6%, that is acceptable. Our patient was given immunotherapy nivolumab, 10 months he developed dysphagia, upper GI endoscopy was suggestive of recurrence, MRI, there was extensive local disease with metastasis to lungs and liver, and he succumbed 11 months post esophagectomy. Salvage surgery can be done safely. It has been shown that salvage surgeries can be done safely, but it has to be done by very well-equipped centers, and there has to be adaptive techniques like retrosternal conduits, colon transposition, long pedicle mental flaps, and other procedures. Complications are high, but the same level of mortality can be achieved, and with same level of mortality and morbidity it can be achieved. So, to summarize, CA esophagus remains a challenging disease. Complete response should be assessed with PET CCT, endoscopy and biopsy, plus minus US if required. Complete clinical response is not equivalent to complete pathological response. Better predictive tools are required. NCCN and ESMO guidelines say that surveillance in patient with definitive chemoradiotherapy with salvage surgery for recurrent or residual disease. NACRT with planned surgery for SCC or observation with salvage surgery in complete responders, both are recommended. Surgery recommended for adenocarcinoma patients even with complete clinical response. Watch and wait with salvage surgery after neoadjuvant chemoradiotherapy can be done with reasonable risk in selected cases of SCC. Results of phase 3 SANO trial and ESOTRATE trial, as Dr. Rajesh was saying, are awaited. Immunotherapy is under evaluation despite advances in chemotherapy, radiation, and surgery. Mortality of these patients with recurrence and disease is high. Newer tools are needed. We have run out of time. We can have just 1 or 2 questions to the panelists if. Yes. It's not working.
So, first comment is what Dr. Sayan said. It is extremely important to decide the intent of treatment at the outset. Because once you decide that this patient is going to be at a high risk for surgery, and if we are able to decide earlier, I'm sure Dr. Sayan would change the dose of radiation he is going to give. Because whatever watch and wait has been reported for CA esophagus, it is outside of a retrospective analysis of patients who decided not to get surgery done for whatever reasons, or for whatever reasons the surgery was not done. This was never studied systematically. What was being studied systematically has been extrapolated from upper esophageal cancers, where a more radical dose of RT has been given. So Dr. Sayan was very, very clear when he said that if his patient has received neoadjuvant chemoradiation, then by and large the patient should have surgery, barring some patients who really decide not to have surgery, or surgery really cannot be done.
Dr. Vivek, that is a different question. If you are doing definitive chemoradiotherapy, then is a different question. So
what I'm trying to say is, if you have given cross protocol, then largely the question of watch and wait generally doesn't apply. When we look at all this meta-analysis that we are talking about, what we have to realize is that the radiation doses are different. The different trials have used different radiation doses.
Dr. Vivek, I would answer.
Yeah.
Even if the radiotherapy doses are different, it doesn't matter, because now you've got a complete clinical response.
That's right.
The translation into PCR is going to be different.
Just hear me out.
Yeah.
And there are data to suggest that offering surgery in these patients may not benefit survival.
Now the data is limited by the fact that different radiation protocols have been used and different kinds of surgery have been used.
These are the patients who got the same radiation therapy who have been followed. It is they are not compared with definite immortality.
Even he's right. Doses of radiation will not matter probably if it is already PCR. Like in breast. If you have a PCR, whatever chemotherapy doses or whatever.
PCR is fine. CCR equal to PCR.
So here our issue is to find out those 60-70% patients who have PCR and select them out for conservative approach and offer surgery to those 30 to 40. All research has to go into this.
I think one more thing that we have to look at, the quality of surgery in these trials. Cross has significant proportion of patients who had a transhiatal esophageal, which today is probably not the standard of care as well. That is also something we have to keep in mind when we are talking about surgery.
Dr. Aseth, last.
Yeah, thank you. I mean, it was a wonderful discussion, and I think we learned quite a few things here. If we finally choose to go on for a wait and watch approach, what will be the follow-up protocols? What do you suggest, how strongly we should be following them up? And what are the modalities are we going to use? Are you going to do PET scans every 6 monthly or 3 monthly to follow this patient? Yearly, endoscopy, US? How are you going to do that? And second part of my question would be, what is the medico-legal aspect of this? Where are we standing if you offer a patient wait and watch approach?
No, these are in the recommendations, so there is no medico-legal aspect to it. The first part of your question.
Regarding follow-up, you can read the protocol of ESO-STATE trial. They have mentioned it in detail. You have to do endoscopy every 3 months in the first year, every 4 months in the second year, and every 6 months after 3 years. So these protocols, if you read, their follow-up has been given in detail.
So I mean, is it only endoscopy-based follow-up? Will it be PET scans?
It would be a PET scan and endoscopy-based.
Endoscopy and PET scan.
So any of you have any experience of following up wait and watch protocol in CA esophagus? Any personal experience? Anyone in the audience? I personally don't have any, so I just want to know.
This is actually very common experience for a radiation oncologist. Many of the cases, after we give radiation, patient gets a good response.
No, I'm not talking about cervical esophagus. I'm talking about lower thoracic or middle esophagus.
Dr. Aseth, we have run out of time. I think I'm afraid we'll have to end it over here. Thank you, panelists. You have done a wonderful job. Thank you so much.
Thank you so much for inviting me.